Welcome, good morning from ACC 2022 in Washington, D.C. I'm Jaya Kanduri. I'm one of the second-year cardiology fellows at Weill Cornell in New York City. I have the pleasure of being here today with Dr. Santiago Garcia, who is the director of the structural program at Christ Hospital in Cincinnati. Welcome. We're so happy to have you. I was really hoping to hear more about your incredible study that we're going to delve into in just a second.
Well, good morning, and thank you for having me here today. So let's talk a little bit about the study. So we call it NACME, the North American COVID-19 Registry. And to understand the motivation for the study, let me take you back to early 2020. You're from New York City, so you remember this probably very well. In the early days of the pandemic, we saw a significant decline, almost 40% decline in STEMI cath lab activations for primary PCI. And so we started to think, why? Why are we seeing these signals when everyone was expecting the opposite? That's what typically happens with the flu and other viral illnesses. And it was very clear from the beginning that some of the public health measures that were instituted to mitigate the spread of the disease, lockdowns, cancellation of in-person visits, and outpatient procedures, were having unintended consequences on STEMI care. So in that context, we designed NACME, the North American COVID-19 Registry, as a collaboration with three societies, SCI, the Canadian equivalent of SCI, and the ACC, to better understand what are the clinical characteristics of patients that have STEMI during the pandemic. So we had two groups of patients in the registry. One group was those patients who had both STEMI and COVID-19 infection. The second group, which served as a control group, were patients with STEMI during the pandemic that were presumed to have COVID-19 infection, but later on ruled out for the disease. So we presented our first initial findings, last year at TCT, and they were published in JACC, and there are unique characteristics of these patients as we learn. The first one is there is a preponderance for ethnic minorities. So more than 50% of patients in the registry were from ethnic minorities, which is unusual for a North American STEMI registry. The second important message from that original publication was that there was a higher prevalence of high-risk pre-PCI conditions, such as cardiogenic shock, in-hospital presentations, and so forth. And the third one was really very high in hospital mortality, almost 1 in 3 patients dying in the hospital, which is very, very high for a STEMI cohort. So what we've done for this study is we wanted to see what are the trends intra-pandemic, because as you know, a lot of things have changed. The most important one is now we have vaccines against COVID-19. So for this analysis we're presenting at ACC, we did a comparison of patients who were treated in 2020 versus those who were treated in 2021. And the main findings are the clinical characteristics of those patients are changing. Now we're seeing the more typical North American population, mainly Caucasian, presenting with more typical ischemic symptoms. So angina is the most common symptom instead of shortness of breath. There is less cardiogenic shock, less in-hospital presentations, and mortality has declined significantly from 33% in 2020 to 23% in 2021. We also conducted a subgroup analysis of those patients in 2021. That's when vaccines became commercially available, and compare those who were vaccinated versus those who were not vaccinated. Now, let me give you context about vaccines, because when we designed NACME, vaccines were in the early phases of clinical development, so we didn't capture vaccine information in the registry. But when they became commercially available, we introduced a protocol amendment. And so we have information in about 58% of patients treated in 2021. And there's a clear difference there in the way they present. Vaccinated patients less likely to present with dyspnea, and none of them expire in the hospital, whereas unvaccinated patients had a 22% mortality. So a significant difference there.
That's really powerful findings, and I think it's amazing that you and your group were able to conduct such a study in the chaotic environment that COVID has been, continues to be. I guess I find it fascinating that we were able to identify that the higher risk cohort did indeed have some discrepancy in the ethnicities that were predominantly affected. And I just wonder if that's, overall pointing towards an issue with access to care and misidentifying atypical presentations in general.
We thought a lot about it and tried to understand what are the drivers. And I think the main one perhaps is how the pandemic affected frontline workers. So if you think about early 2020, many of these ethnic minorities are in service industry, etc. They don't have the luxury of working remotely from home. And this is something that has been described not just for STEMI in general. They were disproportionately affected by COVID-19 in the early phase of the pandemic. As people got more and more vaccinated and we started now to have meetings again and people going back to the office, now you're seeing that yes, you can still contract the disease, but the likelihood of you dying from it are significantly reduced. So I think it has to do with that primarily, the type of work that minorities do in the United States. And so one of the things that we're seeing now in 2021, the population looks pretty much like a STEMI population prior to the pandemic. So there is a sort of that regression to the mean, if you wish. Yeah.
The other question I had was, I know there's hypothesizing about why the STEMI COVID patients were just much sicker on presentation, coming in shock or arrest. And I just wonder if that was more so a consequence of a delay in diagnosis, potentially, as obviously COVID patients are sick with many other respiratory manifestations and so on and so forth, where something like a STEMI could be missed in the clinical context. Was it more so from that, or the fact that these patients truly potentially had a higher thrombotic burden just based on the physiology of how we think COVID is affecting vasculature? And was that sort of identified on angiogram, and was there higher rates of thrombectomy being needed during PCI, and do you think that there were higher risk lesions that were identified if these patients ended up going for angiograms?
That's a really important question, and the answer is multifactorial. So the high risk of mortality is primarily explained by multi-organ failure. So when you look at the predictors of mortality of this population, look very, very different than a typical STEMI population. So in a separate publication, we look at a NACME risk score to predict mortality, and more than 50% of the variables in that score are respiratory. So if you're on a ventilator, if you have abnormal chest X-ray, if you're tachypnea, and so forth, which is unique for a STEMI cohort. And so these patients tend to die from multi-organ failure, not necessarily from the STEMI. But to answer your questions, yes, there were delays. When we look at the patients who went to the cath lab, the door-to-balloon time was prolonged relative to our control group, which I guess is to be expected in the midst of a pandemic because there is a need for testing and so forth. We also noticed, and one of the things we were worried about coming into the registry was, are these patients going to go to the cath lab? That's why we allowed every STEMI to be included, not only those who are going to the cath lab. And unlike some registries from China, we did see that the majority of patients in North America are still coming to the cath lab. So 76% in 2020, up to 86% in 2021 of the patients undergoing invasive angiography, PCI remains the dominant revascularization modality, and 2/3 of patients had door-to-balloon times within 90 minutes. Now, one in five patients undergoing invasive angiography, they had no culprit vessel on angiography, and this entity of microthrombi has been well described for COVID patients. So it is conceivable that many of these patients had plugging of the microcirculation to explain the resting segment elevations, and nothing on angiography to fix with a stent. So we're conducting a separate angiographic core lab analysis to try to understand that. We will certainly look at the use of thrombectomy and other therapies, but that certainly it's a consideration.
And with these amazing results that we have, how do you envision us using the information that we have to sort of change practice as we move forward, whether it's this pandemic or whatever pandemic comes next, in terms of using this to better our own practice? How do you see that happening?
It is very clear, I guess, the take-home message of this analysis on trends is that in 2021 things are better than in 2020, but we still have two groups of patients, vaccinated and unvaccinated, and the outcomes are dramatically different. We have zero mortality among vaccinated patients, and that is, I think, the most important message. Yes, you can still contract the disease, you can still be unlucky enough to have both STEMI and COVID, but if you're vaccinated, the odds of you dying from it are fairly low. It's probably not going to be zero, but it's going to be in the low single digits. In contrast, for those patients who are unvaccinated in 2021, mortality remains quite high, in double digits. So I guess that would be the main message to the cardiology community. These vaccines seem to protect also patients who have heart attacks from mortality in the hospital.